a chance to talk to all of you guys. And I do have a few slides to talk through today, but I guess mostly I was hoping just for this to be a conversation and to, hear where, the folks on the phone are at, what questions people have, and so forth. So I am going to attempt to share my screen. Technology has not been with us today, but let's see if we can make it happen. Great. Can folks see the presentation? Okay, good. Thanks. Great. So I'll just get started. So Carol actually kind of outlined a lot of my career pathway to date. So really in high school and throughout college and medical school, I was involved in HIV activism through ACT UP in an organization called Health Gap. Starting out on the domestic side, looking at kind of needle exchange advocacy, condoms in schools, these sorts of kind of like, very hometown politics, stuff in Chicago and the area. And then moving on to doing more global policy when I was with Health Gap, focusing on global HIV medication access. And that really started in more college and medical school. That work really kind of began to spur my interest in global health. During medical school, I did a few consultancies and early residency. I did a few consultancies with the World Health Organization on access to medicines. And that also got me more involved with organizations like Médecins Sans Frontières and other organizations really working on access to medicines more broadly, even than HIV. Now, when I started my infectious disease fellowship at Penn, I was asked to start the Global Health Equities Residency track, which Carol now directs. That really allowed me to start setting up some curricula and work with students, which I found to be incredibly fulfilling because it made me question. I mean, this is, students always are making folks question kind of like some of their assumptions and kind of like why we do things the way we do. At that point, I'd actually primarily moved to live in Kenya, where I was working clinically, but also doing some operational research and of course doing education and having both clinical and administrative responsibilities at Penn. While living in Kenya, I started working part-time while still maintaining my Penn hat with MSF, first with one of the sections in Kenya, the Brussels section of MSF, working on HIV and TB implementation work, then moving over to the international office to work as the East Africa HIV and TB policy advisor there. Through both MSF as well as some of the work I was doing with Penn, I was also doing some more direct implementation in close partnership with Bagathi District Hospital and the Ministry of Health in Kenya, working on second and third line HIV treatment guidelines, implementation access, and also starting to work on cervical cancer implementation in terms of screen and treat. So then I started working more and more with MSF and started working more with the MSF Access campaign and was asked to move to Geneva to be the medical director of the MSF Access campaign. And in that work, I was very much focused on medical strategy for MSF overall with the other 5 medical directors with MSF, but specifically focused on policy, advocacy, and technical strategy to bring products closer to patients. And so at MSF in the Access campaign, we were really focused on how products needed to be affordable, available, and adapted to the populations with which MSF was serving. And so that meant we had to work across a number of different partners and organizations, everything from big pharma to generics, to the regulatory agencies, to even kind of the World Trade Organization, its role in intellectual property rights, as well as, of course, civil society, and then implementers and clinicians and patients themselves. And so that was my focus for the first, several years I was here in Geneva. But then I was, missing implementation. I'll talk about this later, but I also had my first child. And so I said, the travel I was doing for MSF Access campaign and MSF in general was a bit too much and a bit too unpredictable for starting a family. So I moved over to EGPAF. So talking about work-life balance, I think just kind of like considering when and where roles might happen according to what else is going on in your life. At least for me, it was very important. And so I've moved over to be the EGPAF, which is the Elizabeth Glaser Pediatric AIDS Foundation Senior Director of Innovation. And there I actually started the innovation department there, and I really ran strategic project design, data generation, basically with the goal in mind of access, guideline change, policy change, funding prioritization, and best practice in terms of, documenting and generating evidence for optimal use of products. And I'll talk about one example of that a little bit later in the talk. Then I thought, I've been doing HIV for 15 years, maybe I should try something else. So I moved over to be the Senior Vice President of Cardiovascular Health at an organization called Resolve to Save Lives that's run by Tom Frieden, the previous CDC head. And there we were really focused on speed, scale, and sustainability. So we were taking products that are very well known, simple antihypertensive products and trying to get them to millions of people, working with very large implementers, working with WHO, and really both being a donor, an advocate, and also an implementer. In addition, we were very involved in food policy, which coming from kind of the access to medicines policy world, food policy was even tougher, I will say. And that was just, a really fascinating kind of change. But I missed infectious diseases too much. So I came back to infectious diseases and now am the global access leader at the Global Antibiotic R&D Partnership, again, based here in Geneva, where we're trying to do the R&D to bring forward new antibiotics, work on R&D models and kind of de-linked models where kind of economic incentives are de-linked from developing and commercializing new products, and also focusing on kind of some of the access implementation aspects of new antibiotics that are coming to market either through our own portfolio or more broadly. So that's a little bit about where my overarching career, but then throughout, as Carol mentioned, I've been really focused on providing clinical care because that's, I think, been my touchstone, and it feels like it keeps, my work grounded. But I would say throughout the other thread that's kind of been constant is really improving health in low and middle income countries through access to products and models of care. So, I would say when considering how to ensure access to impactful health products and useful models of care, I like to try and frame it in kind of what are the tools you need, what are the strategies to get them to the people, and what are the policies, including funding, that are needed to support them and to enable access and good health. So basically tools, what are the diagnostics and drugs, what are the strategies, models of care, delivery of care, policies, funding, et cetera, that would actually be beneficial and get these tools to the patients and clinicians who need them. And then in terms of kind of each of these pieces, they all are affected by these items on the right, which I would say are kind of the access factors. So is a given drug available? Is the model of care affordable? Do we have the data necessary to actually change policy? And once we've analyzed the landscape in terms of the tools, strategies, and policies, we also have to figure out kind of the who, what, and how in this other figure that I just put up. So who has the power to improve access to a given tool, strategy, or make a beneficial policy? And who else can actually either help or hinder us? Who do we need to help us convince that decision maker? Is there political pressure? Are there other incentives or blocks? And then how do we deliver it? Who do we work through and what do we need to convince people? So those are kind of the ways I've thought about, I guess, delivering this work on access. So let me give just a couple of examples. So first I wanted to talk about working with hepatitis C when I was part of the MSF Access campaign. And this example is really trying to move an idea from off the table from for the organization I was working for, but also off the table kind of in the global health landscape to action. And so, when we used to think about hepatitis C treatment, we faced a number of barriers. So in terms of the tools, the diagnostic algorithm was really too costly and was very complex. Before hepatitis C, direct-acting antivirals were available. It was injectable therapy that was not very effective. And even when these direct-acting antivirals came to market, they were like $80,000 per treatment course. And so that was priced out of reach, essentially. And there were no generic competition to bring prices down, and no quality assurance for any generic medicines. And in addition, there was no models of care actually to treat hepatitis C in low and middle income countries. This was just simply viewed as too complicated, too expensive to even think about designing models of care. And there were kind of emerging, but very still nascent advocacy and organizations to really build demand and force the political hand of people who might be able to fund or put forward these programs. And then in terms of policies, there weren't any normative or WHO guidelines that either existed or were sufficiently simple for use in low and middle income countries, so they were not well adapted. National guidelines, for the most part, didn't exist. Direct antivirals were on an essential medicine list, and basically no one was funding this, governments nor international donors. So we worked, a group of us from a number of different kind of entities within the big MSF umbrella thought, this is important. This is important enough where we are going to start planning internally and kind of push internally for this idea until it could be on the table both within MSF, and then MSF is really great because it forces things onto the table for other actors. So we thought, what could we do? Well, first of all, we couldn't even diagnose hepatitis C with the current diagnostic algorithm. It was simply too complicated. And fortunately, the direct-acting antivirals actually allowed for simplification. So it was a little bit of a chicken and egg, but we said, let's assume we can get access to these direct-acting antivirals. What would the diagnostic algorithm look like? So we went outside of MSF and we grabbed some folks from Penn, actually Val Amorosa is a colleague in ID. We grabbed some folks from, academia. Both Maud and Andrew are in academia, and we published what could we do? How could we simplify diagnostic identification and monitoring for hepatitis C, given these new drug products? So if we had this, it breaks down. If we had these treatments, it'll break down the barrier of diagnosis. We also worked on pricing for hepatitis C viral load, which is key in monitoring hepatitis C. So we got tiered pricing, so lower and lower middle income countries had lower prices that were brought it closer to affordable. And then we worked with generic manufacturers to look at the business case, build the cost of goods, and actually begin to say, hey, it might make sense for generic manufacturers to enter into the market and produce direct-acting antivirals. And what we saw is basically within a couple years of when we started this work, manufacturers started coming online. There was a number of other steps in between. I'm shortening it, but manufacturers coming online. And what we saw very rapidly is these are worldwide prices for a 3-month course of treatment, sofosbuvir-based treatment, direct-acting antiviral. And we saw in the US, $84,000. In Pakistan, $150,000, and that's even lower now today with additional generic competition. And we said, great, we're going to publish this because the world should know how cheap and effective we can actually treat this deadly disease. So then we said, okay, now that we've got the tools, we can actually build a model of care, and MSF is the perfect organization to do that. And so we worked with MSF missions in countries to start developing a much more simplified model where nurses could diagnose, where we could get community health workers to support patients, even including in getting refills, to make sure that these models of care were not super centralized, didn't require liver specialists to actually roll out. And now that we had treatment that we knew could be available, we could begin to work with civil society and activists and get folks really fired up, because this was now within people's reach. So we also worked and wrote some editorials and kind of nudged a big donor, Unitaid, to provide some funding for hepatitis C, which was previously outside of Unitaid's scope. Unitaid focused on HIV, TB, and malaria. They, as you note, hepatitis C got into HIV and they had to add co-infections, but we nudged it onto the table for them. And then finally, we worked with the WHO and national ministries of health to improve the guidelines so that there were normative guidelines that were evidence-based that could support the rollout of these products. So we actually contributed to systematic reviews for the treatment of hepatitis C, as well as the testing of hepatitis C. We actually, through MSF, we submitted a essential medicine list application to the WHO, which was successful for one of the important hepatitis C treatments. And as I mentioned before, we got even more donors to actually support this. So now the Global Fund, which was previously Global Fund for HIV, TB, and malaria, also supports hepatitis C. So that's a little bit about nudging something onto the table. And now I'm going to talk about some work I've done with EGPAF, where it's expanding the overall scope of an organization. So EGPAF, as some people might know, is a large HIV implementer. They've been around since before the inception of PEPFAR, which is the US bilateral HIV aid program. And they're one of the main implementing partners for PEPFAR. They're active in about 15 sub-Saharan African countries. They do a ton of work for PEPFAR. But what they hadn't done is kind of worked on pushing the envelope and looking at innovation and linking innovation to access. So that's where I started working at EGPAF to kind of expand that role. So first we defined what innovation was, and we thought, yeah, new health products that are not there or they're underutilized. That's clear, but we can't leave off service delivery, because innovations in service delivery can be as impactful or more impactful as the products we bring. And as I mentioned earlier in the talk, they're intimately linked. You can't just drop a new product in often without a model of care to actually support its appropriate use. And so we made kind of this innovation kind of cycle where we said, we're going to landscape, we're going to scan the horizon, and according to a rubric, we're going to identify different innovative products or models of care that we want to prioritize. We are going to design implementation that will be catalytic. It will work not only on building the evidence and generating the models of care to change guidelines and build funding rationales, but it'll also work on the access aspects of affordability, availability, national drug registration, et cetera. And then we are going to build all that work into generating the evidence necessary to catalyze change much more broadly, even in those 15 countries in which we work. And so I built, with a couple other fantastic folks at EGPAF, built a few teams. This is my, if you can see my pointer, this is my TB team at headquarters. We also had an HIV team at headquarters. And this is one of our country leader meetings that was held in Rwanda, but this was on our HIV early infant diagnosis program. So I'm going to talk just for another 5 minutes or so about one of the programs that we focused on while I was at EGPAF, which is on point of care early infant diagnosis. So essentially, as many people know, each year about 180,000 new children are newly infected with HIV, most of these perinatally. Unfortunately, diagnosis of HIV in infants is not as simple as it is in adults, because adults we test for antibodies. Infants have antibodies from their moms, so they will be positive even if they are not infected with HIV. So we actually need a direct test to look for the HIV virus itself, an HIV viral load, which requires nucleic acid testing, looking directly for that RNA. And unfortunately, for kids who are infected with HIV, time is really of the essence. So 50% of kids who are infected in utero die by 2 years of age, with a peak mortality at 8 to 10 weeks. And there's also been data that each day without treatment means the virologic control, getting your HIV under control, is more difficult, and kids lose neurologic function. So this is like every day counts. We got to get these kids on treatment. Unfortunately, the systems were not built for speed. So what we had at that point when we first started working on this is very centralized testing for viral load or early infant diagnosis. So a specimen would be collected at the facility, it would go by, transport to the laboratory, it would be analyzed at the laboratory. Often it would be, people would wait until they could get a full batch of like 96 different samples to run, and that could take a while. And then you would send the result back. If you were lucky, you got it sent back by an SMS printer, if that was still working. If not, it was physically returned. And then you had to get that result into the clinician's hands with the caregiver all together to actually make a clinical decision. And that took 30 to 90 days. And I'll show you real world evidence that shows that it's often longer in many of the countries in which we worked. So this whole 8 to 10 weeks we missed. We couldn't get kids on therapy by the time that we really needed them. So here again, what are the tools, strategies, and policies that we could use? So fortunately, point of care nucleic acid testing for early infant diagnosis came onto the market. And there were 2 different products at that point, and they were quality assured in terms of, they were not quality assured at that time by kind of like a WHO body. But they were certainly not affordable, and they were not approved in any country. So we said, all right, we have some barriers, but this is probably important. We also, didn't necessarily know if the models of care were feasible to use them in a very decentralized way. So, like birth is a pretty, like usually not medically intensive thing, so it can be very decentralized. But could this sort of product be decentralized so the point of care part of it could actually be used well? And who could use it? Could nurses use this? Did a lab tech need to use this? And then finally, policies. So neither national nor normative policies, WHO policies, existed to use this. And in fact, the major donors, both PEPFAR and Global Fund, we were frankly opposed to using this. They said, there's not the data, they're too expensive, no. So we said, all right, let's figure out how we can get these products in, build the evidence we need, simplify the model of care so it's feasible, and bring the costs down. So first we said, we got to get these products in so we can start doing all this work. So we advocated for either waivers of regulatory filing just to start the work, or we submitted the appropriate, with the manufacturers, help submit the appropriate documentation so that they could get actually approved for use, for routine use across 9 countries in sub-Saharan Africa. We did a ton of negotiation with both of those manufacturers. We developed our own cost of goods data to do advocacy with, to reduce prices. And we also achieved this all-in pricing offer, which I won't get into. But essentially, we did achieve fairly significant reductions of 40% for the Abbott MPEMA platform. So again, fairly significant reductions in costs. We also, I'm not going to get into that piece, but let me just move quickly over to here. And then we also said, all right, can people actually use this, and how do we maximize the use in a decentralized way of these kind of, more expensive type of products and platforms? So basically, we set up a hub and spoke model. So where a number of very small facilities, which, maybe saw like one birth a week or so, HIV exposed birth a week, and sent them to a hub, which could be, basically we defined it as less than an hour transport away. And transport was defined by, it could be walking, it could be a car, whatever was normally available. So they could send it nearby rather than far away to a capital city. And this resulted in a 6.6-fold increase in access per platform. And we also documented that actually you didn't need a lab tech to run these platforms, to prepare the samples, to run the results, to interpret the results and get the results back. This was basically a comparison between nurses and laboratory techs on the errors that they made. They made about the same amount of errors, and mostly they made them immediately after they started training over here, and then they went down and kind of stayed stable. And also in terms of the result return, it was about the same. So nurses could do this. We could decentralize this and do it in a way that was fit to the infrastructure and human resources that was available. And so then we said, all right, now we got to change some policies. So we published a number of studies on both cost effectiveness, but also the impact of this model of care. And we communicated to them, to key stakeholders. All of the national ministries of health rapidly actually adopted their guidelines, mostly ahead of the WHO, and said, actually, this is really working well. This is saving babies' lives. And WHO finally moved it to a strong recommendation just about a year and a half ago, which took a while, but it did happen eventually. And then I think kind of one of our biggest wins is that both PEPFAR and Global Fund decided that yes, based on this evidence, they would fund point of care early infant diagnosis. And then finally, we worked very closely with activists, so tons of different activists. We also worked with kind of like the first ladies who were care very much about the children in their countries, and really tried to, build an advocacy platform. So just a few final thoughts before I close. And some of these are kind of very like cliche-ish, but I guess there's like a reason for cliches. I would say just, in terms of career pathways, it is important to follow your passion and, make sure that you're excited about the work that you're doing. And if you're not excited about it, move, like find something you are excited about. I would say networking, talking, collaborating, following up is the way that I've always kind of found my, what I'm doing next and like my next collaborator, my next project, etc. It's been important, at least for me, to make sure I've got kind of the latitude for creativity and the flexibility to like figure out this path because it's not necessarily a traditional path. Find your people. So this is that, just kind of to note that it's been really important for me to be with not necessarily people who think the exact same thing as me, but people who challenge me and who I'm like excited to talk to every day. And so, for instance, like when I was thinking about, do I want to do a fellowship or not? I thought about, well, who do I want to hang out with in the hospital? And I thought, oh, I kind of love hanging out with the ID doctors. Those are my people. So find your people, and that's like, that'll be kind of your career home. And then surround yourself with people who will both support and challenge you. And then just to say, yes, work-life balance is super important. This is me and my family this past October. And yeah, I mean, I changed I loved working for MSF, but it was a better fit for my family to work at something where I could plan my travel a little bit more. And maybe I'll go back to working with MSF when my kids are a little bit more grown up. But I think it is important to make sure that, the pieces of your life fit well together. So that's it. Thank you, guys. Do you guys have questions or comments? It'd be great also to hear what you all are thinking.
That was such a wonderful talk. Thank you so much. And thank you for taking the time to come speak to all of us today. Really appreciate it. If anyone has a question, feel free to come off mute or enter it in the chat. But go ahead, Megan, do you have one?
I do, but I was going to say I'd like the young people to ask some questions before I do.
I had one question to kind of start us off, if you don't mind.
Yeah.
Just working in so many different organizations and not all based in the United States and everything, and then your work outside of the States, how did you navigate some of the different cultural norms in these different countries and working at these different governments, kind of helping to determine priorities?
Yeah, so I would say for me, it's been incredibly important to work with colleagues who have been working in whatever context it is for a long time. You know, for me, one of the most strong things about EGPATH is that, as you saw, the leadership of EGPATH was primarily people who were born, grew up, went to medical school, did their residency, like met all the other like leaders of medicine, you know, in that country or in that region, and really to work closely with them in a collaborative mode. So when we were designing the projects that we did for EGPATH, you know, on HIV treatment, on the point of care EID that I talked about, on our TB work, it was really very much hand in hand with the appropriate leaders, you know, because there's, you know, some HIV specialists within the country teams, some of the TB specialists, in our country offices, and in collaboration with other kind of like thought leaders in that context. And so from the inception, you know, that's critical. You can't just kind of say, all right, I've got this pre-baked program, let's all implement it, because people are going to be like, you don't know what you're talking about. For this context, it's going to need to look like this, and then you have to go back and start at the drawing board. It's really critical to actually get people who know what they're talking about from the beginning.
Thank you so much.
Students, any other questions? I'm going to start calling on you.
Yeah.
Priya, I know you, so I know you have good questions.
I really don't have much questions, but it was a great talk. Thank you.
Thank you.
One of the things which I was curious, since the slide where you showed the pharmaceutical pricing, which was very interesting. Pakistan is $150, while India is, I think, 400 and something. United States is like 84,000.
Yeah.
Same ad. So how, one of the questions which I was very curious about, well, maybe you did cover it, in terms of focusing on India, because my research would be only in India. How did you manage to get them to do that kind of pricing?
Yeah. So I think there's a couple things. One is, at least in high income countries, drug pricing is fairly delinked. It doesn't reflect the cost of goods and cost of manufacture, and is very much more value-based. What will the market bear? So I think there's a number of things that in HIV and hepatitis C that we've seen to be able to bring prices down. One is moving manufacture to manufacturers that are kind of like generic manufacturers, many of which, as you know, are based in India, also called the pharmacy, to the developing world. So already moving there is just kind of lower overhead. But I think more importantly, the thing that really gets pricing down is that the model there is much more about a cost plus model. So what is the cost of manufacture plus a reasonable profit, because generic manufacturers for the most part are for-profit companies. So cost plus is much more prevalent there. You know, what we've seen is that actually the cost of manufacture can be quite cheap, whereas the price is completely something different. We've also seen that, you know, so generic manufacture is probably in competition where, you know, kind of like the core of American capitalism kind of brings prices down, right? So that is probably the biggest, by far the biggest driver of lower costs in many generically produced medicines. The other thing that we've seen is price transparency. So, you know, documenting and publicizing the cost of goods so that, you know, governments themselves have a better idea of what a fair price might be and can negotiate based on that. So you reduce kind of those information inequities so that people have more of a, you know, even ground to negotiate on. And then also price transparency in terms of not just the cost of goods, but the actual price of products, and benchmarking products is another way that you can improve pricing, especially in a market where there's a number of different manufacturers. And then finally, there are a number of things that you can do to kind of like, bring prices down based on efficiencies. So looking at things like pooled procurement, so where you take a number of different demand and you pool them all together so you have bigger leverage to procure, kind of like organizing your orders so that the manufacturers can be more efficient in terms of when they produce their batches, harmonizing kind of packaging so it's a little less anyway, there's like a number of things that can be done, the biggest of which for certain markets where multiple manufacturers are needed, the market is big enough, is generic manufacture and competition. I think it's more shocking like how the US like tolerates these really high prices, but that is what we do.
Thank you. I just want to extend this question a little bit more. $484 and $150 in a developing country is a lot of money for people.
Yeah.
They can't even afford 16 cents for electricity.
Absolutely.
So I wonder what the customer base is. I mean, is there going to be a huge subsidy the government gives for them?
Yeah, I think that's a great point. And that's where, where it's really important to say health, it should not be on the market actually at all. Like health is not something where you have any way to kind of negotiate. It's like your life or your money. That's kind of not a great market approach. So just to say, as you know, India does have one of the stronger public health networks, and really working with governments to make those investment cases, thinking about health technology assessments to demonstrate their cost effectiveness or figure out the price point at which they will be cost effective for a given government to include in their kind of basket of products. They might include either for severe discounts or in India's case actually for free for people who qualify. I think those are also important because it could be cheap to when you look at it compared to the US, but that's still not necessarily affordable. And then, I think that there are a number of countries that may not be able to include some of these, products for free. And HIV is a classic example. ARVs are free in the public sector in most low and middle income countries in sub-Saharan Africa. And that is because of large amounts of international funding and subsidization there. So, I think there are a number of different mechanisms that we can think about, but I think that, Priya, this kind of calls into question for me, like a larger question of, how are we pricing medicines in general? And how can we make sure that kind of the investments that we make as a public sector result in products that actually can be affordable and accessible to the public. So I think that's a whole nother massive question.
Thank you.
Yeah, thank you. But I also would love to hear kind of what you guys are doing while you're thinking about that. I do see there's a question in the chat just commenting on leaving academia for MSF and what went into that decision making. Family considerations. So it was a hard decision. I really loved my kind of like working at Penn, and I've stayed working at Penn. I think the nice thing about academia is you can kind of keep a foot in. So, maintaining a role or kind of like some sort of appointment in academia, even when you are working elsewhere, I think makes the academic, both your own career, but also the academic community more rich. And I think the best academia is flexible like that, recognizing that, the academia should be a big tent and bringing in lots of different ideas and experiences and negotiating that as you go through your career. If you do want to maintain a foot in academia, I think I'm certainly not the only one who does it. There's tons of affiliated faculty or other faculty that, do something else 90% of their time, but keep a foot in academia because it is a place for kind of enriching, challenging discussions. But I wanted to be more deeply involved in work that was primarily in advocacy and in implementation. And I wanted to work for an organization like MSF. But it took, 3 years of me kind of with my primary hat of Penn and MSF kind of like, paying to release some of my time to make that decision. So, and then the family considerations, I think the major one was just, opting for a position where I still traveled a ton. I was traveling about 30% of the time, I think post-COVID induction or whatever we're going to call it, because we're not exactly post-COVID. Things will change in terms of how much we do feel like we need to travel. In addition, if you can rely on partnerships more and strong leaders, there's less of a need to travel. Yes, in face-to-face meetings for brainstorming and like big project stuff is going to always be critical. But hopefully travel will be just in general less for folks who are entering into global health. It's wonderful to travel, but it is difficult with a family. So I traveled a little bit less. I traveled 30% of the time rather than like 50, 60% of the time. And I traveled at a more predictable pace. I wasn't kind of like packing a bag with a plan to leave in 2 days. So I think that is important. It was really important for me to be there predictably for my kids and then to warn them like when I was going to go and that I would be back, and I knew when I would be back and so forth. So, and for my partner as well, I don't want to leave him out. But I'd say that for starting a family, that was the biggest consideration, is just the disruption with travel. But yeah, would love to hear what you guys are thinking about as well. Okay. What is there's another, I'll read this while people are thinking. Oh yeah, go ahead, Miranda.
I think it's the one Liz just put in. What is one lesson you've learned in the field that you think may be beneficial to share with us so we can learn from it too?
Flexibility. So flexibility and being open to kind of like suggestions and kind of ideas that may maybe even fundamentally change your program. Now, if your program is like a stringent research, thing, you have less room to change, but for implementation and policy change, you've got to be nimble and flexible. And that is really important. So keeping your eye on like the big goal, but the way you get there is going to go like this.
Thank you. We also have another question in the chat from Hannah, who's a program manager for global health informatics at CHOP. We are in our first year as a newly formed program. How did you come about choosing your projects and where you worked? Were there agreements already in place with local government, local leaders, and ministries of health?
Yeah, so when I first started working with Bagathi District Hospital, it was really through connections. And, one of the things I really have valued is, just connections. I mean, the way I started working with MSF, I'll start there. So I worked in ACT UP. Through ACT UP, I started meeting people in Health Gap. One of the people in Health Gap, Sharon Ann, a colleague that I still work very closely with, went to work in a mission in MSF in South Africa. She said, I have to go and take some leave. Can you fill in for me on this one mission? So I filled in for her. I did another mission. Then I, through that mission, I met a ton of people. And one of them said, hey, we really need more support on access in East Africa, blah, blah, blah. Went to Access Campaign. In Access Campaign was working on diagnostics, ran a big viral load project. Through the viral load project, met folks who are working on early infant diagnostics and started talking about, oh, wait, early infant diagnostics, that's really critical. This is a huge, gap where no one's working on this. Worked with EggPath, started working on that project, went over to EggPath, worked on that project. And so it's really just, it's in some ways, it's like I said, you talk to people, you start thinking about something and you say, hey, I want to work on this thing. sometimes you can work on that thing within your own organization. Sometimes it's better if you chose a different organization on which to work on that thing. And then in terms of kind of like the partnerships, again, EGPAF had really strong local teams. That was super critical, really important. MSF similarly, but quite different because of the model in MSF. And that was one of the things I was most impressed with about EGPAF, is how you could really have these like rich, kind of like more stable, long-term local teams that really had developed very high level leadership profiles. So that was incredibly important. MSF, as folks may know, this is changing now, but really works on this rotation basis of a lot of very specifically and intentionally not local folks. And so it's a very different model, but did have, obviously, MSF has a huge and deep network. So anyway, so that was kind of a little bit, it's really kind of a bit opportunistic, and just kind of like talking and learning and hearing what other people are doing, like brainstorming with people and figuring out what you want to do, and then just kind of like figuring out where you need to be to do that thing.
Thank you. I just put a note in the chat box that Dr. Cohn will be a featured speaker in our Building Effective Global Health Partnership series. So you may, Hannah, want to attend that to learn more about her actual work and the operations of that. And back to your career, I wanted to ask, first of all, thank you so much, Jen. I loved learning about how you made your transitions, and I loved seeing the picture of your family too. So we have a lot of MPH students on this call, and they actually organized this whole series, and thank you to them for doing such a great job.
That's awesome. Thank you, guys.
Yeah. And I wanted to ask what your advice to them are. So I know some of them on here have some global experience because they were Peace Corps volunteers. Some may not have had any, but in the organizations with which you've worked, where do you see sort of the early career entry level opportunities for MPH students?
Yeah, I mean, I would say definitely EGPAF, especially if you have Peace Corps work, which requires a lot of project management. EGPAF is a big implementer. It's a lot about project management. MSF, if you are able to travel and are able to, a first mission is 6 months. There's very few exceptions to that, unless there are specialized needs in a certain emergency. If you are able to travel, MSF is a pretty unique and pretty exciting organization. And once you do, first of all, I mean, some missions, especially in stable contexts, can be years and years long. So MSF isn't just like flying around the whole time. It can be actually you're there for quite some time. Once you do that, you can begin to like choose which missions you want to go on, or maybe, think about headquarters roles, etc. And so I would say that, and certainly, again, people who have Peace Corps experience, people who have project management experience, those are the bread and butter. I mean, yes, you need medical people for Doctors Without Borders, but honestly, the thing that I think is the reason MSF is so successful is its logistics. It has really good logistics. And that requires project managers and logisticians. So that's like the backbone, to be honest. So I would say those two organizations do have entry-level positions that are very hands-on. You meet a ton of people, and I think it just depends on kind of like what your life will fit.
Thank you. Anyone else? I think we're pretty close to the time anyway. So thank you.
Thank you guys so much for inviting me.
Oh yeah, you were perfect. I'll let Miranda close things up, and we will see you again soon, Jen.
Yeah.
Yes, thank you so much for taking the time to speak with us. And thank you, Megan, for asking that last question. I feel like it really resonated with me. I'm an MPH student and I was also a Peace Corps volunteer, kind of now looking to enter the career world, and I'm inspired. But thank you so much for being the keynote for our global health or Career Pathways and Global Health Week. We really appreciate you taking the time. And everyone, please go register for Dr. Cohn's next talk for Effective Global Health Partnership Series that Megan put in the chat. But that is all. Thank you so much.
Thanks again for having me. Have a great weekend, everyone. Thank you.
Thank you to the
Bye
students
all.
too.
Yes, thank you for the organization. Amazing. Bye all.
Thank you.
Bye. Have a great weekend, everyone.